Thank you very much. It's truly an honor to be here and to be a part of your program. I tried for a few years to get here and join you, and I'm glad to finally be able to join. I'm also embarrassed to say I'm at this point in my career that I have never been to Cairo, so I am pleased to fix that problem and to come and visit your very beautiful city. So thank you very much for your warm welcome. The previous speaker set up my talk very nicely in describing quantitative imaging biomarkers. And I have been asked to share a bit about imaging of progressive MS. I'm going to address that somewhat superficially and then turn to the fluid biomarkers and take a deep dive into neurofilaments and to review what we know about neurofilaments with progressive MS. And I'll give you a hint, it's a little disappointing. It's exciting for relapsing MS, but for progressive MS, it's not turned out to be as good as we had hoped. So first, here are my disclosures. My institution requires me to show these every time I give a talk, and so here it is for you. When we image MS, imaging progression, we have come to learn that new enlarging T2 lesions, although critically important for relapsing MS, for identifying disease activity, identifying response to our relapsing MS therapies, these have limited relevance in progressive MS. Therapies that reduce new lesions, even if they reduce new lesions in progressive MS, they tend not to slow the progression, the insidious decline of progressive MS. So what do we use instead? Well, there's a number of different imaging modalities. I'm going to review them here in a very superficial way due to the short time. But most commonly used is brain atrophy. So whole brain atrophy is most commonly employed as the primary outcome of phase 2 trials in progressive MS. It has a face validity, makes sense. Shrinkage of the brain seems like a bad thing, and if you can slow down shrinkage of the brain, that's probably a good thing. And it represents the end organ damage of the organ of interest of ours, being the brain. And so measuring that seems to be of relevance. But there's a couple things to appreciate regarding this. This is so-called spaghetti plots that show the change in brain volume over time in individual patients. And what you can see is that there's quite a bit of variability here. So we have a patient who goes up a little bit, then goes down, and then goes back up, and then is stable, and then goes down again. Now, in general, you can appreciate most of these patients have a going down trajectory over time, but there is a lot of variability from test to test. That goes back to the previous talk about the variability, and indeed there is a lot of variability in brain atrophy, which is making it of limited utility in individual patients. We can take average, because the average up should balance out the average down, but within individual patients, it's a little bit harder. We've also come to appreciate the challenges of different tools. So only a few studies have compared directly one way of measuring brain atrophy to another. So BPF here is on the bottom, and on the vertical axis is Sienna, perhaps one of the most commonly used brain volume algorithms. Both of these have been employed in clinical trials, and this is a graph showing the change in brain volume in a clinical trial, comparing patients measured with Sienna versus patients measured with the Cleveland Clinic brain parenchymal fraction tool. And what you can see is, well, yes, there is a correlation, but you would expect it to be a much higher correlation than that. In fact, there are some patients who have a decline in brain volume with one tool and an increase with another, and then some that are in the other direction as well. So going back to the temperature, if you think you're going to measure minus 10 degrees Celsius with one thermometer, minus 10 degrees Celsius should be with the other thermometer, but the analogy here is that you might have some that are a little warmer and cooler, even though from just two different thermometers. So the tool turns out to be more important than we appreciated. And indeed, taking this data from here and applying it across the 4 different treatment arms of that particular trial that this was applied to, you can see quite different results. In the 8 milligram group, Sienna showed an increased brain atrophy where BPF showed not much at all. Here, the 4 milligram group, Sienna showed a decrease in brain volume where the BPF didn't show much change. The placebo showed a decline in both. You can see there is quite different results. Same MRIs, same patients, same trials, just a different measurement stick for how brain atrophy was measured. Well, what about other tools? There are many, many other ways of interrogating the brain to understand what's going on. You can look at segmented atrophy, atrophy of different individual areas of the brain, cortical thickness, thalamic atrophy, cervical cord atrophy. I think we're going to hear more about the spinal cord a little later today. Magnetization transfer ratio, diffusion tensor imaging, spectroscopy, functional MRI, and there are many others. But I just point out a couple of challenges when we think about integrating them. This is diffusion tensor imaging in a descending pyramidal tract in a brain. Well, you have to decide what is the descending pyramidal tract in that brain MRI. And you can see here that there are a number of different areas that may or may not be found in one patient. We include some fiber tracts out here. There's this little red fiber tract here. We got some over here as well. You can imagine if you do that repeatedly over time in the same patient or compare across different patients, you'll be capturing different parts of the brain. So there is some variability in how we deploy these tools. Similarly, this is an MTR measure, and where on the brain are we going to look? Do we look in the lesions? Do we look in the normal appearing brain tissue? Do we look in the whole brain? So standardizing this, and again, this goes back to the previous talk, standardizing these quantitative imaging measures are a very important aspect. This is MTR at baseline in patients in a multi-center clinical trial, and looking at the average whole brain MTR. And it is according to which manufacturer, so 1.5 T versus 1 T, so strength of magnet, which manufacturer, GE, Philips, or Siemens, and then the different types of magnets and coils within them. And what you can see is that depending on what specific magnet setup you have, the average MTR in the patient's brains may be quite variable. Now, the patients are variable, we know that over time, but we know that these differences, like an average MTR here versus up here, it's because of how the MTR is being acquired. So there are dramatic differences across different platforms of acquiring data, and so MTR is different depending on how it's acquired. So we look at just change over time. And so this is from that same trial. This is the dimethyl fumarate Tecfidera trial. And you can look at the change in MTR and feel confident, oh, okay, well, placebo went down, some stabilization in one dose, maybe an increase in the higher dose of BG12. Okay, well, I feel good about that. Well, what's not shown on this slide is that the standard deviation, and if you apply the standard error, the standard error, that's the standard error of estimating the mean. Well, if you actually apply the standard deviation, this is what the graphs look like. Not very pretty anymore, and not nearly as compelling as they were before we had the variance. So again, highlighting that these imaging metrics are quite variable. And it is one of the challenges in how we apply these metrics to understanding therapies and understanding individual patients over time. Well, lately we've heard a lot in progressive MS about compartmentalized inflammation. So inflammation not from the periphery going in, creating focal lesions, new T2 lesions in MRI, but inflammation within the brain, behind the blood-brain barrier. So there are a couple of things that we think are related to that or may capture that. Paramagnetic rim lesions, slowly expanding lesions, PET imaging for microglia, and post-contrast flare. Now these are somewhat newer modalities, things we haven't heard about so much until the last few years. And so let me take a brief deep dive into one of them, paramagnetic rim lesions. So these lesions are thought to reflect a chronic inflammatory state behind the blood-brain barrier, so within the brain, that is around lesions, and is thought to arise from magnetic disruption of the MRI by iron-laden macrophages and microglia. And that because of the active compartmentalized inflammation, there is iron that is taken up by the macrophages of microglia, and so they may signify areas of ongoing chronic inflammation. How do we see that on imaging? Well, it's a multi-step process. So one, we have to pick a T2 lesion. There's a number in this image, but for this purpose, we're looking at this image, this lesion, on a T2 weighted FLAIR image. So we look at that as a starting point. And then we look at both the phase EPI and the T2 star EPI and ask, is there a dark ring around the lesion? So we say, yes, there is a dark ring around the lesion, and there's a dark ring at least partly around the lesion. And then we have to go on to a third step and say, we have to look at the post-contrast T1 weighted image and make sure that there is no gadolinium enhancement, because where there is gadolinium enhancement, it can create what appears to be a phase rim, but we don't consider them phase rim because those are the active inflammatory lesions, the focal inflammation. So those are the steps that are used to define phase rim lesions. And then by measuring them, measuring their development, and measuring their disappearance, we think we are capturing something about the chronic compartmentalized inflammation. So I know that was very brief, but let me just summarize. We have many imaging methods to characterize tissue pathology, its injury, and its eventual destruction. Each of these methods have their own challenges when it comes to progressive MS, when it comes to MS across all types, within and between patient variability, challenges with standardizing across platforms so that the way we measure one is the same across the other, or at least a translation factor, uncertain sensitivity to change over time. And although right now whole brain atrophy is still the most commonly employed primary outcome for phase 2 trials in progressive MS, I think the time is coming when other modalities will replace it. And indeed, there are some phase 1 early 2A studies which are employing others of these metrics that may turn out to be more sensitive and more powerful. All right, let me turn in the second half of my talk to fluid biomarkers. And what do we know about fluid biomarkers of MS, with particular attention to progressive MS? There are many things we can measure in MS, including progressive MS. Cell surface markers, cytokines, chemokines, various things related to the inflammatory cascade, the antibodies themselves, oligoclonal bands or autoantibodies, and then we can look at the CNS-specific proteins, so myelin and myelin breakdown proteins, and then things related to cell death and cell injury, such as neurofilaments and GFAP. And I know many of you have already heard about neurofilaments and the excitement around measuring them with MS. So let me briefly, as applied to progressive MS, review, well, what are neurofilaments? It's important to understand that as we think about progressive MS. And then how can neurofilaments be used as a prognostic marker, a predictor, and how can they be used as a treatment response marker? So first, neurofilaments. These are highly specific neuronal proteins, so neuronal, both central nervous system and peripheral nervous system. They comprise 85% of the CNS cytoskeleton protein, so they are the bulk of the steel girders that are within neurons to hold them and establish their size and their shape. They're relatively resistant to degradation, which is good, so that when they spill out into the CSF and eventually into the serum and plasma, they are easy to measure. So they become a cross-disease neurologic biomarker, and as you can imagine based on the description, it is a biomarker of any CNS or peripheral nervous system injury. So traumatic brain injury, stroke, epilepsy, seizures, so any sort of insult to the brain can be captured through its release of neurofilament. So what do we know about them? This is a study that did monthly blood draws and monthly MRIs to identify when patients develop new lesions, and then to look at the corresponding serum then and for the months after to see how serum neurofilament captures. And what you can see here is that neurofilament does not increase at the time of GAD lesion, but actually soon thereafter. And you can also see it doesn't increase in all the patients. There are a lot of patients who stay down here who don't increase their neurofilament. Now, it is related to the number of lesions. Patients with one lesion hardly have any elevation in neurofilament, 2 to 3, a little bit more, 4 to 9 more, and then if you have over 10, the vast majority of those patients have an elevation in their neurofilament, but you'll see a couple of them don't. Even 4 to 9, a couple of them do not have elevation in neurofilament. So you can see that this is a sensitive measure of tissue injury for active inflammation. I'm sorry, it's a specific measure, but it's not sensitive. There's a lot of patients with brain activity that's not reflected in neurofilament. All right, so then how do we measure it? So there's a couple different platforms that are available to measure. This is out of a company named 𝐷. They're using their NFL Lite Advantage kit. This is out of Siemens. They have using their large machine as well, and 𝐿ABcorp has a method as well. Now, why do I mention that? You'll see in a moment. There's also some freestanding laboratories like Mayo Clinic Laboratory in the United States. They have an NFL, but if you look under a little bit more deeply, turns out they are using the Simoa HDX analyzer, which is this 𝐷 machine. So what is normal? It's important when you use a test, you know what normal would be. So with 𝐷, normal, and 𝐿ABcorp, I'm just going to choose the 51 to 61 age as just a random comparison across. And you can see that with 𝐷, normal is 15 picograms per mil, but when we get down to 𝐿ABcorp, normal is under 3. Well, that's a little different. But even when we look at Mayo Clinic, which, as you'll recall, uses the 𝐷 methodology, the Mayo Clinic, looking at that same age, 50 to 59, their normal is under 20.0. So it's either 15 or 20.0, even when you use the same tool. Well, that's a little complicated. So the normal cutoff values are very variable between machines, and even within the machine, depending on what lab is using the same machine. Well, this is a group out of Johns Hopkins and the MS Paths Collaborative, and they took their MS patients and said, how many of our MS patients have abnormal based on 97.7% cutoff, a standard 2 standard deviation cutoff? Well, for this, it depends on what your reference population is. If they use the healthy controls within their study, there were 17.8% that were abnormal. But if they used a U.S. National Healthy Volunteer database, turns out it was only 2.9, the 𝐬𝐩𝐸𝐬𝐳 database. So depending on who your normal controls are, some may be more normal or less normal relative to your patient population. And then when they looked and said, well, what are the difference between those two control populations? Well, it turns out diabetes and prediabetes was much more common in the 𝐬𝐸𝐸𝐻, and diabetes does increase neurofilament. We also know that increased age will increase neurofilament, and body size will alter neurofilament, and so does kidney function. So it turns out there's a lot of nuances when it comes to NFL to understand it. So it's not just a single value, abnormal or not. So let me turn now to a trial prognostic marker. Is it predictive of things? And the answer is yes. So this is a longitudinal study out of Basel, Switzerland, that shows that higher levels of NFL at baseline were associated with a higher rate of disability progression. And this is from 2 progressive MS clinical trials, the siponimod secondary progressive trial on the left, the ocrelizumab primary progressive trial on the right. And again, NFL at baseline, in red, has a higher risk of progressive disability over time than patients who had a low NFL. So it's predictive. That's encouraging. And again, here, brain atrophy, the same studies, siponimod on the left, ocrelizumab on the right. The baseline NFL is predictive of brain atrophy progression over the time of the study. But hold on, not quite so fast. This is a Dutch observational cohort that looked at patients on natalizumab where the active inflammation was subdued and taken out of the picture. And now we see that those with confirmed disability progression versus not, it really didn't matter what their NFL was. So when you take active focal inflammation out of the picture, it's not predictive. This was another study from the natalizumab secondary progressive trial where they looked at just patients without any active inflammation, so no relapses, no new lesions and MRI, and said, how predictive was NFL of future disability? And the correlation is 0.12, 0.16, terrible correlation. Sometimes it's even negative, negative 0.14. I was part of the group that saw this, and the lead author said, oh, well, this is terrible, we shouldn't report it. I said, no, 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 this is truly insightful. This is very important to know. We have to report this, and that's why it went into a JAMA Open, because it shows how when you take active focal inflammation out of the picture, the predictive capacity of NFL disappears, and it's not predictive. So it is related to focal inflammation, and that's still very important, but in terms of progression, it's not related. So NFL is a prognostic marker of future disability, activity, and disability in progressive MS, but only if there is disease activity. When you take disease activity away, it's not really helpful. So how might we be able to use it? You can use NFL as entry criteria, but it's sort of reflecting patients with recent disease activity. And hopefully you'll be looking at an anti-inflammatory therapy to understand, and there is confounding with other conditions like age, diabetes, and kidney function. So to me, it has an unclear incremental contribution as a trial enrichment tool beyond looking at previous relapses and MRI disease activity. All right, finally, let me turn to NFL as a treatment response biomarker. Can we use this as an outcome to replace, say, whole brain atrophy in our phase 2 trials of progressive MS? So this is from relapsing MS first. We see a relapsing trial of fingolimod, and we see a nice, robust reduction in NFL. And this is from a more contemporary trial of a second-generation 𝐬𝐩𝐸 inhibitor, vidofludimus, and we see, again, a reduction in NFL with active treatment compared to placebo. When we turn to progressive MS, our positive progressive MS trials also show a benefit. So this is the EXPAND trial of siponimod. You have heard about this yesterday, of course. And we see a nice, not terribly large, but a definite reduction in neurofilament with the active treatment compared to the placebo. And also ocrelizumab in the primary progressive trial, another positive trial, we see a reduction of neurofilament with active treatment compared to placebo. All right, so it works. It also works in a negative trial. So this is MD1003, the high-dose biotin, showing no effect of treatment on NFL. Indeed, there was no treatment effect either clinically. But then things fall apart a little bit. So this is the INFORMS trial of fingolimod in primary progressive MS. On the right side, you see the disability progression curves superimposed, so no treatment effect. But on the left, you see that there is a treatment effect on NFL. There is a reduction with active treatment on NFL on the left, even though there's no benefit on disability progression on the right. Similarly, the ASCEND trial, natalizumab in secondary progressive MS. On the left, you can see a profound reduction in neurofilament with natalizumab, but on the right, there was a failed primary outcome, a slowing of the multi-component progression. Ibutalas, this is a phase 2 trial I helped to organize. On the left, showing no effect on neurofilament, even though on the right we showed about a 48% slowing of progression of brain atrophy over time. And then the MS stat. So this is a statin trial that was organized out of London. On the left, you see no impact on neurofilament, even though on the right you do see a reduction in progression of brain atrophy with the simvastatin compared to the placebo group. So in summary, serum neurofilament is probably useful as a treatment response marker in relapsing MS, but it has not demonstrated a role in progressive trials except as a marker of focal inflammation. And in fact, in several trials, it was misleading in that it was positive with an anti-inflammatory drug, even though the clinical outcome was negative. So with that, I will stop, and thank you very much for your attention.